I just want to elaborate on this comment. When it comes to bleeding risk, yes, both the quantity of platelets, which is the platelet count, and the quality of platelets, which is how well they work, do matter. Women who are pregnant are more likely to have lower platelet counts than women who are not pregnant. If the platelet count is less than 150,000, and there are no other causes for this, it's called gestational thrombocytopenia. It's pretty common, about 10% by the time of delivery. With gestational thrombocytopenia, the platelet count is usually over 100,000, and we generally don't worry about it too much. Even with this physiologic or normal decline in platelet count in pregnancy is overall a procoagulant or prothrombotic state because of other changes in the coagulation system. Meaning when you are pregnant, you are more likely to clot and less likely to bleed than when you are not pregnant. It's a cool way our body sets us up for the bleeding that can happen. It also means there is a higher risk of blood clots, especially when you add in other risk factors. So what about platelet quality or function? Normally when we talk about this, it's in the context of preeclampsia. We know that patients with preeclampsia, especially HELLP syndrome, we not only see a very low platelet count, but also the function of those platelets can be affected, which leads to an even higher risk of bleeding. With ITP, there are also qualitative changes in platelets, but this is variable, as is the bleeding risk. So in these patients in particular, a bleeding history of easy bruising can be very helpful with risk assessment. I don't know if I would say what's more important, but we certainly need to be more mindful of some of these other aspects outside of just the platelet count, depending on the patient's history.